Good morning, good afternoon, good evening. Welcome to another WSO webinar. My name is Selina Schwarz and I'm the Executive Manager of the World Stroke Academy, the official educational platform of the World Stroke Organization, and we are very happy to host this educational activity today. Today's topic is a highly relevant clinical topic, timing of starting anticoagulation in ischemic stroke with AF. And we're very happy that we have an expert panel joining us today with Professor Suwanwela from Thailand, Professor Caso from Italy, and Professor Werring from the UK. Also joining us is Ye Liu, who's from the WSO Research Committee and who will moderate the Q&A session, and will also introduce our first speaker now. So I'll hand over to you, Ye.
Hello, everyone. My name is Ye Liu, a stroke neurologist from Shanghai Huashan Hospital in China. Now, let me introduce our first speaker. Professor Nijasri Suwanwela is a professor of neurology in Chulalongkorn University in Bangkok, Thailand. She is also the president of the Neurological Society of Thailand. Her talk today will focus on what is the current practice and guideline for initiating oral anticoagulants after ischemic stroke with atrial fibrillation, and why we still need new evidence. Professor Suwanwela, please.
Thank you very much, Yi. Hello, everyone. So I was just going to share my slides. So thank you very much again. I'm very honored to be part of this webinar on the initiation of oral anticoagulant after ischemic stroke in patients with atrial fibrillation. And this is my disclosure slide here. So before I talk about the guidelines, let me just start by telling you about a patient. This is one of a patient of mine, and she's a 75-year-old lady who presented in the middle of the night because she was found collapsed on the floor, and she had left hemiplegia and full syndrome of the right MCA territory stroke. She has history of atrial fibrillation and hypertension. She was on NOAC. And last dose was 19 hours ago, which is less than 24 hours. And her CT scan shows that she had dense MCA sign on the right, as you can see over here. So since she was on NOAC and it was less than 24 hours, so we went on and had CTA and CT perfusion on her. You can appreciate that the right MCA is occluded, and also there's a mismatch on the perfusion study. So we immediately brought her into the angio suite, and thrombectomy was performed. She was markedly improved. NH was down to 3 after the treatment. So this is one of the lucky ones that she came in and we got rid of the emboli, which went up to the brain in time. So she was pretty much markedly better after the treatment. But what's next? In this case and in other atrial fibrillation cases who had stroke, there's a risk of having another emboli in the near future. So generally, we would say that these cases would have around 1% per day of risk of having another emboli to the brain. And the patient that I showed to you was the lucky one. But there are some patients who are not very fortunate. Like in this patient, she came in later with a left MCA stroke, and we delayed anticoagulation because of the large infarction. And a couple of days later, she developed another stroke on the other side of the brain. So she had bilateral MCA infarct, and you can probably predict the outcome of this patient. So in general, we would say that it's the risk of having another stroke would be higher during the first or acute phase after the first one. And the number that I mentioned earlier, that it's 1% per day, is based on a study a very long time ago, based on a few patients. But usually we would say that it would be higher during the first period after stroke. More recent studies show that the risk of having another stroke during the first 14 days would be around 4 to 8%. So that's still high. So it's agreed that the risk of having another stroke is high in early phase after stroke. Right. And these are the factors related to early recurrence of stroke in patients with atrial fibrillation. So the risk is there. And we know that recurrent stroke can be prevented by anticoagulant. But we have to balance between the risk of having another stroke and the risk of bleeding side effect of the treatment. Professor C. Miller Fisher used to say that if you are treating even one patient in your practice with anticoagulation, you should wake up once a week or so in a cold sweat. So although we kind of currently have much better anticoagulant with better efficacy and less bleeding like the NOACs right now, the risk is still there. So as I said, we have to balance between the risk of having another stroke during the first couple of weeks and the risk of bleeding, especially the risk of intracranial bleeding, the hemorrhagic transformation of the previous stroke, which is generally around 1 to 10%. And the risk is higher in patients with large infarct and the ones with cardioembolism, which is definitely our cases with atrial fibrillation. So what about the guidelines? What do they say about this issue? Let me start with one of the vague ones. This is from the American Heart Association and American Stroke Association in 2019. They mentioned that for most patients, it's reasonable to initiate oral anticoagulation between 4 to 14 days after the stroke. So they didn't really mention about the exact timing, how to start anticoagulation. So it depends mainly on the physician's preference. Another guideline, actually these are the two guidelines from the Australia and New Zealand part of the world. The guideline from the Australia Stroke Foundation and the Cardiac Society of Australia and New Zealand in 2018 and 2020. And they mentioned that anticoagulant should be delayed until 2 weeks after the onset of stroke. So this recommendation is later, 2 weeks after the stroke. And in both guidelines, they kind of agree in this time frame. They also mentioned a bit on the patients with TIA or minor stroke, and anticoagulation could be started early, but they didn't really mention when would that be. So mention that delay up to 2 weeks, and then the decision should be made before the patient is discharged from the hospital. There are some guidelines that are more specific on the timing, and this is the European Heart Rhythm Association guideline. Since 2013, they recommend this number 13612 day rule. So if the patient is having TIA, you can start it anticoagulation within the first day, after the first day, and then mild stroke, non-disabling, 3 days and 6 days for moderate, and 12 days for the large ones. And this is also, again, emphasized in the most recent guideline from the same association. And if the patient is having TIA, can start after first day. If the patient is having mild neurological deficit, 3 days, and so on. And they also recommend to perform another neuroimaging of the brain before starting anticoagulant, especially the ones with moderate and severe stroke. There are many other guidelines which also use the same number, 13612. For example, this Indian stroke guideline and also the Chinese stroke guideline also uses the same number, but there's no evidence, real evidence on that number. Another guideline from the European Stroke Organization, and this guideline mentioned very clearly that they cannot recommend the real, based on any randomized control trial, but based on expert opinion, they recommend to start anticoagulant based on the severity of stroke and also the size of infarct. So the figures is a little bit different from the ones that I mentioned earlier, that 13612. And this guideline mentioned that maybe we can start the treatment at day 3-4 if the patient is mild stroke and small infarct less than 1.5 centimeters, 7 days for moderate infarct, and more than 14 days for the severe one. And they also recommend the use of antiplatelet within the first 48 hours, and then switch to anticoagulant later. So this is what they recommend. So mild, moderate, and severe, and large infarct, and also antiplatelet before giving anticoagulant. regarding the antiplatelet treatment before starting anticoagulant, there are some other guidelines which also mention about this. And this is the Canadian stroke best practice. And they mentioned that bridging with antiplatelet therapy is suggested until the patient's anticoagulated. So we have to think about that too. I'm sure there's no true evidence on these cases, but there are some recommendations on this. And another recommendation would be about bridging between heparin, low molecular heparin, before starting anticoagulant, the oral ones. And in this EHRA guideline, they kind of suggest to use NOAC in these cases. So bridging of heparin before starting NOAC is not recommended because everybody knows that NOAC has a very rapid onset of action already. So you don't need to bridge them with the heparin or low molecular weight heparin. So in summary, I think it's pretty clear that there's no consensus between the guidelines on when to start anticoagulant in patients with atrial fibrillation and recent stroke. Some guidelines mention that you should start anytime between 4 to 14 days. Some mention that you should start later on after 14 days. And some are more specific in terms of the days of starting, depending on the patient severity and also the size of infarct. So I believe this question, when to initiate anticoagulant after stroke in patients with atrial fibrillation, is an extremely important clinical question that most of us have to face and make decisions for our individual patients. And I think it's almost every day that we have to do this. And many guidelines are trying to give recommendations. However, none of them are based on RCT, which specifically designed to answer this question. And the recommendations are basically based on expert opinions only. We definitely need more RCTs, and I'm glad that many of them are ongoing right now. I'm very much looking forward to hearing about the results of these studies in the near future. Thank you very much.
Thank you for the talk, Professor Suwanwela. Now let's move to the second talk by Professor Valeria Caso from University of Perugia Stroke Unit in Italy. She is the former president of the European Stroke Organization. She has been involved in 20 multi-center trials, serving in various positions, including steer committees. She will talk us through what are the evidence from RCT and the large observational studies on initiating oral anticoagulants after ischemic stroke with atrial fibrillation. Professor Caso, please.
Hello, everybody. I'm very honored to be here and to speak about atrial fibrillation. You know that the University of Stroke, and you know that the University of Perugia did many researches on this topic. These are by conflict of interest. So why, and you see the previous speaker said this very clearly, why we are so, why we have so many difficulties in deciding when to treat our patient. Because, for example, if you look at all the anticoagulation trials, for example, the BAFTA and so on, they never included secondary prevention patients. Same is for the NOAC. If you look at the percentage of patients with previous stroke in the different studies, you can see that there were only 20% for the Relial, 90% for the Aristoteles, 28% for the Engaged, and but at least 55% for the Rocket AF study. So globally, we had only a small number of patients who had already a stroke and when they are anticoagulated. We know that there's no difference. There's a net benefit for DOACs, especially regarding intracranial bleeding. But if you look at the timing, and you know, we need randomized trials to share and to have our decisions. If you look at the timing, Aristoteles started, patients were included after 7 days. Aristotle excluded all patients within 7 days with a previous stroke or hemorrhage. Rely excluded the patient with stroke within 14 days. Record 14 days, and we know, we heard this already, there's a high risk of recurrence in his first 14 days, and engage 30 days. So we started to work on this, and I give you a short overview of the history, because I will not speak too much about the randomized trials, because this is really something ongoing, and David will talk about this more. But we put together all the data from VISTA, and we saw that, again, the best timing was between 2 to 3 days. Then we designed the rough study, because the rough study was something that we decided to do as there was no evidence. And you know that these observational studies, our rough studies, where we collect all the data on how was the current practice of anticoagulation, we saw that that within, if you start to anticoagulate between 4 and 14 days, you have the best timing of having what we call the net benefit. The net benefit combining together ischemic recurrence and hemorrhagic transformations. And however, in this first rough study, we had only 93 patients who were on DOACs. So so we decided to redo it only in patients who had were under NOAC. And you see again what we call the net clinical benefit, protection from ischemic stroke and hemorrhagic recurrence was in the first 4 to 14 days, with even a lower event rate. So in order not to overlap too much with the talks with the other talks, I will show you some sub-results from some results of our rough cohort. For example, you know, there is a lot of false belief that posterior stroke patient have more events compared to anterior stroke patient. So we designed a stroke trial, a stroke registry, where we collect only patients who were under DOAC but had posterior circulation stroke, and then we compare it with the anterior circulation stroke, and you see there is no difference in the combined endpoint between there was no higher risk for ischemic stroke, and there was no higher risk for hemorrhagic endpoint, and also the timing was the same. So the idea that posterior stroke tend to have more bleeding was in a way was not confirmed. What's about the lesion size? And you saw this very well in the previous talk. The lesion size, the larger the lesion, the higher is the risk of having a recurrence, and not only symptomatic hemorrhagic transformation, but also due to the fact that we have more ischemic complication. What does it mean? Is this because we can only anticoagulate them quite late? Or is it due to the fact that we have, due to the fact that the lesion is large, the stroke is very severe, per se creates a higher risk for these patients? Again, the same is when, the same is when you compared small lesion compared to large lesion. Clearly, small lesions have less complication when they are anticoagulated. Here, just to I give you this overview to see what was done in before. Now we are doing this randomized trials, which will be then presented by David. So we have different observational studies, and you see what was the most important point is that the hemorrhagic intracranial hemorrhage was quite low and lower than we expected. So it's clear, we know that there is a reperfusion damage when you have a cardioembolic lesion. You have a higher risk of ischemia. But at the end, these data show us that we were, let's say, ready to design randomized trials in order to start a recruitment for patients with atrial fibrillation. Here, just to show you this, this is another paper that we worked together, just also to confirm what we heard before. The using DOACs reduce the risk of having intracerebral hemorrhage. So a lot of recurrence, because a lot of data that we had before regarding the risk of hemorrhagic transformation were based on old data using vitamin K, using heparin, and the better profile of the DOACs was mainly to the fact that we have less bleeding events and therefore a better combined outcome. What's about the patient who are treated with reperfusion? And also this, there are some, we looked at the data of patient treated by reperfusion. If this could influence the risk of having ischemic or hemorrhagic recurrence. And you see that the treatment with reperfusion did not influence the outcome. I will not speak about heparin because you heard this already. It's clearly showed in our data that heparin increased the risk of hemorrhagic complication and ischemic complication. I think these are all this false belief that heparin you can dose it, you can modify it. Sometimes also because the patient has nasogastric tube, you prefer to use heparin, but there is no evidence from the data. And this is also confirmed by a recent study published on stroke, the YAC study, where you see clearly there's an increase of hemorrhagic complication. Just not to overlap too much with my speakers, with the speaker who will come now, I just want to show you the latest research that we are doing now is to understand why we have recurrence even on patients who are taking NOACs. And you see that not all recurrence that we have in patients treated with anticoagulation are due to cardioembolic stroke. So we have small vessel disease, large vessel disease. So this is the RENO study, and you can see what is the main reason why patients have recurrence, because we don't use the anticoagulants in the correct use, so dose. So we treated our patient with low doses when there is no indication to do it. And you see in this graph how much the risk of hemorrhage, ischemic events increase by the low doses, especially by the non-labeled low doses compared to the hemorrhagic risk. So we tend to give something which is not reduced the efficacy of our drugs without having really a benefit, because these patients will have an ischemic stroke. And clearly, the higher is the CHA2DS2-VASc, the higher is the risk of recurrence. I have to show you that women tend to have often more recurrence, and they are chosen for lower doses. So just to remind you, treat the women right. And to finish, I just wanted to show you this study done by David Werring, which is, I think, very interesting, because you see there is a risk of having ischemic stroke despite of anticoagulation, even in patient NOAC naive, even those who had DOAC. And he also wanted to understand if there is something that we can do, for example, changing the anticoagulation therapy or leaving the same as it is. So there, as you can see, there is no difference in this. So just to summarize, the optimal timing of anticoagulation after acute ischemic stroke in AF is basically based on observational studies. There is no evidences on bridging with heparin, and thrombolysis and endovascular therapy should not delay anticoagulation. And the future direction, I will not speak about this because this will be then done by David. Just a small future direction, what we are doing, we are collecting now all the patients who were on anticoagulation, had a stroke despite of the best treatment. We want to follow up this patient, see how physicians are currently treating this patient, and to show you the best possible management of these patients. Thank you very much for your attention.
Thank you, Valeria. Okay, now let's welcome our last speaker, Professor David Werring. Is Professor of Clinical Neurology and Honorary Consultant Neurologist at the Stroke Research Center, UCL Institute of Neurology in UK. He is head of the Research Department of Brain Repair and Rehabilitation at the Institute of Neurology, chair of the Association of British Neurologists Stroke Advisory Group, and on the editorial boards of several peer-reviewed journals. He will introduce ongoing trials and summarize today's talk. Professor Werring, please.
So my topic is going to be talking about ongoing trials in this important area, and then just briefly summing up. And the other speakers have set the scene really nicely for this talk that I'm going to give. These are my disclosures. And perhaps the most important one is I'm chief investigator for the Optimus trial, and I'm also a grant co-applicant and leader coordinating site in the UK for the ELAN trial. So before I start, you may be interested in this review article, which contains more detail on the background to this important question, which has been very nicely summarized already. But if you would like to look in a bit more detail, this review may be of interest, which is written by the chief investigators of the ongoing randomized controlled trials. So we've heard already from the speakers that the clinical dilemma is an acute ischemic stroke associated with atrial fibrillation. We need to balance this risk of early recurrence of embolism and ischemic stroke, which is of the order of 1% per day from some of these studies. And this needs to be balanced against the risk of intracranial hemorrhage and principally hemorrhagic transformation of the infarct, as shown here. And we can see that these risks are rather finely balanced, as we've already heard. And the key point, of course, is that altering the timing of anticoagulation could alter the balance of these risks. So if we give anticoagulation earlier, we have the potential to prevent early ischemic stroke recurrence. But this then could come at a cost of increased bleeding, because we know that large infarcts particularly can have hemorrhagic transformation acutely. So by contrast, if we give anticoagulants later, there may then be less risk of bleeding, but a higher risk of early ischemic stroke recurrence. So this is why, as we've heard already, it's a very live question in stroke medicine, a very common dilemma on our stroke units every day. So what are we doing in this field, and in terms of current practice? And I just want to briefly show you this survey from the UK, where we had a response from clinicians at most of the stroke units in the UK. 121 clinicians responded, and 95% said there was an uncertainty about when to anticoagulate in atrial fibrillation associated ischemic stroke. Only about a third of people in the UK at this time were following the 1-3-6-12 rule that we've heard about from Nijasri, and 88% of the responders were willing to participate in a randomized controlled trial. And what this graph shows you is along the x-axis we have the days after a TIA or a stroke, and on the y-axis we have the number of respondents. And each of the colors is a different clinical scenario. So the survey gave people different clinical situations from a yellow, the yellow bar is TIA, the blue is for a mild severity stroke, green is moderate, and red is a more severe clinical stroke syndrome. And you can see that there's a great consensus that TIAs should be treated very early, which we'd all agree with, I'm sure. But then in the mild, moderate, and severe strokes, you can see there's a trend for more severe strokes to be treated later and the mild strokes to be treated earlier with anticoagulants. But you can see a very great range in the practice in this survey. So I think this very clearly demonstrates the uncertainty in this clinical field. And we've heard very nicely from the previous talks about the reasons for that uncertainty. And I think we've already seen some of this data as well from Valeria, clearly showing that DOACs have a lot of promise over vitamin K antagonists in this acute setting. But this is observational data. And although there seems to be evidence for a lower bleeding risk and a similar ischemic stroke risk when given acutely, this was within a median of 5 days after the stroke, we have potential for bias and confounding, and we need randomized controlled trials. So I'm just going to outline these 4 ongoing randomized controlled trials and give you some of the similarities and differences of the trials that we're looking forward to gain data from to inform this important clinical question. And I did a recent search on clinical trials website, and these are the only 4 large-scale randomized controlled trials that I'm aware of. And the first thing to say is that they are all pretty large. So they're called ELAN, Optimas, Timing, and START. And 3 of these are based in Europe, and 1 of them is United States. And as I said, the first thing to mention is that they're all pretty large. The START trial is 1,500 participants, going up to 2,000, possibly more now for ELAN. I think the sample may have gone up. Timing is 3,000, and then Optimas is 3,500. So the good news is these are large trials, and together they should provide good, precise estimates of the event rates. And importantly, they will have randomly allocated the treatment. So we'll be able to disentangle the confounding effects of observational data. This summarizes the intervention and the comparator for each of those trials. And the thing to note is that the ELAN trial is giving a different time window of intervention with an oral anticoagulant, depending on the severity of the stroke. And this is defined according to the size of the infarct. I'll briefly talk about that shortly. The START trial is an adaptive design. And again, it has a different time to treatment delay, depending on the severity of the stroke syndrome. By contrast, the Optimas and the Timing trials both have a simple time window of intervening with early anticoagulation in day 4 or before in acute ischemic stroke, with a control comparator arm of a later time window of between day 7 and 14 for Optimas and day 5 to 10 for the Timing trial. So those are the key differences in the allocation of the treatment between the trials. And just a little bit more detail on the ELAN trial. This is taken from the ELAN website, which shows that different DOAC timings are allocated based on the size of the infarct. And the logic of this, of course, is that larger infarcts we know have a greater propensity for hemorrhagic transformation than smaller infarcts. And the hypothesis is that early treatment may be more hazardous in these large infarcts. So I won't go through in detail, but you can see here that there are different time windows for early and late treatments in minor, moderate, and major stroke after the onset of the stroke syndrome. And let's just have a look at how do they classify the severity of stroke in the ELAN trial. So this is a classification into minor, moderate, and major. It's not a clinical severity, it's infarct size. And this is based on observational data that I think Valeria mentioned from the Perugia team, showing that there were higher rates of hemorrhagic transformation in larger infarcts. But the caveat about these observations is that they were based largely on pre-DOAC data, and they don't really give us evidence that the timing of the DOAC or the oral anticoagulant actually interacts with this infarct size in terms of the key outcomes of recurrent ischemia and hemorrhagic transformation. So I think it's fantastic that this has been incorporated into a trial design. It's going to be very interesting, but it's also going to be interesting to look at some of the other trials which have a different way of dealing with this, looking at subgroup analyses after the trial has been completed. So just a brief word about the START trial. So this is led by Steve Warwick in Texas. It's a multi-center trial in the United States, and it's a very interesting design which applies a response adaptive randomization mechanism. And what this means is that there are going to be 4 time to treatment arms, and essentially interim analyses will be done in the trial, looking at each of these time windows within the first 14 days for mild to moderate stroke, or within the first 21 days for more severe stroke. And as those results come in, the allocation will be biased in favor of those arms which are showing a more promising benefit in terms of the composite overall event rate. That's my understanding. And it's a very interesting design, and you can read more about this in the protocol paper, which is published in the International Journal of Stroke. The trial is also designed to include 1,000 patients of mild to moderate risk of bleeding complications and 500 who are at higher risk. So this again is a very interesting trial design, and we're looking forward to the results. The timing and the Optimas trials are very similar in their design. And in fact, expertise has been shared between the steering committees of these trials. We're in close contact, as well as in contact with the other trialists, of course. And timing is led by Jonas Aldgren. It's a Swedish trial, and it's based within the Swedish National Stroke Registry, which is a very interesting design process by which all patients in the National Registry are offered randomization. It's an extremely promising way of increasing research participation. And in this trial, participants are randomized to 4 days or less in the early intervention arm versus 5 to 10 days in the later comparator arm. There is no restriction or mandated timing based on infarct size or stroke severity. Patients can also be included if they're taking an oral anticoagulant at the time of the stroke. This is an important point because this could be up to about 1 in 3 people are taking an oral anticoagulant at the time of their stroke associated with atrial fibrillation. In the Optimas trial, which is a UK-based trial, it will be run at around 100 hospitals within the United Kingdom. Patients are going to be randomized or are being randomized to 4 days or less as the intervention versus 7 to 14 days as the comparator arm. And this was based really on our intelligence from the survey that we did and from the UK guidelines. So it was tailored towards the views and the guidelines of UK stroke physicians. And it's based within the National Institute for Health Research Network and the Clinical Research Network. And just like timing, there's no restriction or mandated timing based on infarct size or NIHSS stroke severity. And this is the equipoise principle. So investigators are encouraged to randomize any participant in whom they're unsure about the timing of oral anticoagulation. And I hope the previous trials have very clearly shown us that, in fact, this should be virtually all of the patients. We should have equipoise here because the evidence simply is not there to tell us when these patients should be treated. So just to summarize the follow-up periods, slightly earlier follow-up for ELAN at 30 days and START at 30 days, whereas Optimas and timing have their primary follow-up at 90 days. ELAN and START will have secondary outcomes at 90 days as well. And all of the trials have a similar composite outcome, which is a typical composite of major bleeding, recurrent cerebral ischemia, systemic embolism, or vascular death. And the good news here, though, is that basically we have quite similar outcomes. And I think there is huge potential once these trials complete for us to work together as investigators and to pool data with ideally individual patient data level meta-analyses to give us even stronger evidence once the results begin to emerge from all 3 of these clinical trials. Finally, patients with hemorrhagic transformation can be included in all of these trials. And in the Optimas trial, we've emphasized clinical equipoise as the guiding principle, and no NIHSS exclusions except for the START trial, which is only including people with NIHSS of 3 to 23, so excluding the very mildest and the most severe stroke syndromes. The end dates, now it's a bit difficult for me to know the end dates of these trials because we've all been impacted severely by the COVID pandemic. And I know that the Optimas end date, as this is the one I'm most closely involved in, is likely to shift quite some time, possibly into 2022 or even 2023, although we're working as hard as we can on recruitment. And I think probably there's some uncertainty about the end of the other 2 trials as well. In terms of recruitment, Optimas has currently recruited about 750, I think. Timing, I believe, is recruited around 1,000, and ELAM, I believe, around 1,000, although I don't have the very latest data, and I don't have the latest figures on the START trial recruitment. But it is promising that all of these trials are continuing despite the pandemic, and we're definitely going to have data in the next year or 2, or even before that for some of the trials. And sorry, I'll just emphasize we're all working together in these trials, and there's good cooperation between all the trials, and I very much hope we'll be able to work together with pooled analyses. So what should we do at the moment? Well, I'm obviously biased here, but this is what we put in the Lancet Neurology Review from the trialists, and that is, if you have a trial available, you should offer participants enrollment in a randomized controlled trial of early direct oral anticoagulant therapy, wherever that is possible. And we've put a guideline here that you may wish to delay therapy for those with severe symptomatic hemorrhagic transformation, which would be PH type 2 from the ECAS and the Heidelberg classifications. But again, this is something we really don't have good data on, and we're relying on the equipoise principle in Optimas and in timing at least. So offer a trial, but if there is no trial, then we've heard that 14 days or less is probably reasonable. Mild to moderate stroke initiation earlier at day 4 to 5 seems safe from prospective observational data, 1 small randomized trial. But for more severe strokes, a longer delay might be reasonable, but we do not know how long that delay should be. And as Valeria mentioned, the evidence does not really support bridging with heparin or heparinoids, particularly now in the DOAC era. And I'm going to just sum up the take-home messages from all of our talks today. The optimal timing after acute ischemic stroke with AF is a common and very difficult clinical challenge. We don't have good evidence of benefit with early treatment with heparins or vitamin K antagonists. The guidelines internationally are inconsistent, highly variable, not based on high quality evidence, and such evidence as there is mostly from the pre-DOAC era. The guidelines are also unclear on how to handle the issue of stroke severity and stratification of treatment. Clinicians remain extremely uncertain and strongly support trials, and early anticoagulation with DOACs certainly looks really promising. It might be safer than we thought, given the older anticoagulants, but randomized controlled trials are urgently needed and thankfully are ongoing and recruiting. And I'll just acknowledge some funders there. And I thank you very much indeed for your attention. And I'll stop at that point. Here's some further reading. Thank you very much.
Thank you, Professor Werring. Actually, thank you all very much for the talk today, all our speakers. So now let's start the Q&A session. We actually have already have quite a lot of questions about the hemorrhagic infarction, but I think Professor Werring has already stated that in the last few slides. So, but people still want to know, so what's the rule for the hemorrhagic infarction, as it's quite common in the stroke patients with AF. Is the rule of 4 to 14 days or 1, 3, 6, 13 days still applied? Is absorbed completely, or is there any better ways that we should handle these patients? Yes.
If you want, I can answer this, because when you're speaking about hemorrhagic transformation, you have to, there's a classification. So there are sometimes some hemorrhagic transformation with some small petechiae, or you can really have a parenchymal hematoma, which is the one which change completely the prognosis. In case of parenchymal hematoma, it's clear, especially PH2 from ECAS, you have a high risk of death and recurrence. But you have to, and you have to postpone anticoagulation, and you have to reperform a CT, because you will have in this case also a clinical worsening of the patient. But in case when you have the small asymptomatic hemorrhagic transformations, the small petechia, honestly, we, especially considering the high risk profile of this patient with some petechia or with HT2, we tend to start anticoagulation, monitor the patient clinically, because we want, what gives us the real guideline is the clinic of the patient, and start anticoagulation. Different is with severe parenchymal hematoma. Then we have to delay it. We are not waiting for the complete reabsorption of this hemorrhage, but normally we tend to wait 1 week, and when there is a satisfying radiological feature, then we restart.
I would agree with everything Valeria says there. I think hemorrhagic transformation is part of the biology of some of these of large embolic infarcts because of reperfusion injury. I must say I have a bit more uncertainty than Valeria about the significance of the PH2. It's clearly a bad thing, but whether giving a DOAC would actually worsen that process, since it's really an ischemia reperfusion injury, I don't know the answer, but I'm probably not brave enough to randomize somebody with PH2, having said all that. But I think really the message should be that we should be randomizing people into trials so that we have really good evidence on this instead of expert consensus.
Yes, just to clarify, HT, so hemorrhagic transformation, not parenchymal hematoma. When you have small petechia, I would start.
Yeah, me too.
But again, you need to do another brain imaging before starting, right? Especially for the ones with parenchymal hemorrhage.
Yes, absolutely.
Well, we always do that, don't we? But I've got a patient at the moment actually with a big infarct and a lot of bleed. We've scanned them now 3 times with CT scans, and the blood is gradually fading a little bit, but it still looks quite alarming on the scan. But we don't know what that means. It's just evolution of the blood products. Whether it makes it safer because it looks of lower attenuation on a CT scan, I'm honestly not sure. But it makes us feel better, and it makes us more reassured, but I don't think the biological explanation is really there for that.
Yeah, absolutely. This is absolutely the point, because we have the extravasation of the blood. So we have iron, we have products from hemoglobin, which are really irritating more the brain. So absolutely, to say now, should we start or not, or what kind of significance it has, I agree with you, it's extremely difficult, because you took a photograph of the damage, but you took not a photograph of the future and the evolution.
And you don't know the interaction of the timing of the anticoagulant. But hopefully we'll have some subgroup analyses of these trials. If people randomize some of these really challenging patients, then we'll be able to have data on those subgroups.
Okay, here's another very interesting question, and I think it's already presented in Professor Suwanwela's talk. So an AF patient is already on NOAC, no matter what type it is, and having another stroke. So I think there are 2 types of the questions here. So first, what's your management in the acute phase? Do you withhold the NOAC or continue the NOAC? And the second is, after the acute phase, what's your choice for the secondary prevention? Did you stick on the same NOAC or change to another type, or just doing maybe the left atrial appendage closure? So what's your opinions for that?
Okay, that's a very hard one, isn't it? if nobody else has taken it, I'll just briefly say that this is an increasing clinical dilemma. It's I think about a third of patients are on a DOAC at the time of their ischemic stroke from AF. And David Werring and others in a big European collaboration have got some evidence that first of all, the recurrence risk is really high in these patients. So it's definitely right to be worried about the ischemic stroke recurrence risk. But I'm not aware of any evidence that switching the DOAC is going to make a better outcome as opposed to continuing with the same DOAC. Personally, it seems logical to perhaps try and consider a DOAC either with a different dosing schedule or with a different mechanism of action. So direct thrombin inhibitor versus a factor 10A inhibitor. And the important thing is to maybe measure the levels and see if the patient was actually taking the DOAC at the time of the stroke, because that makes it a lot easier. If you've got low levels or poor compliance, you've got a clear explanation. And then just finally, don't forget other mechanisms, because large vessel atherosclerosis and cerebral small vessel disease can also cause strokes in these patients, and they might not be stopped by DOACs.
I agree with David. What we show from what I show you with the Seifke paper is that these patients have a high risk. Now, what we are doing in Perugia, we are together with many centers all over the world. We are trying to give you a snapshot on what is done. So how many patients changed the anticoagulation treatment? How many patients associated aspirin? What is the stroke mechanism, which also is an important point, because if it is lacunar stroke, it is probably different from a recurrence of an embolic stroke. We also try to understand if there is something that we can do on lifestyle, because if you have a patient which is on the best DOAC dose and so on, without control of hypertension, dyslipidemia, and so on, so it's clear that you have to have this holistic view of your patient. So it's not enough that you say we are looking at the anticoagulation, the type of anticoagulation, what did we wrong, but we have to look of the global health of this patient.
Yeah, in my center, most of the cases who had stroke after NOAC, they would have poor compliance. So compliance, I think, is one of the important things to consider. If the patient didn't take the medication and they had a stroke, so I think it's justified to go on back onto the same drug that they are using. But if they're still having the drug when they have a stroke, maybe you have to consider other things that you mentioned earlier.
And I would just add, I think there's a real need for clinical trials in this area, looking at maybe novel antithrombotic combinations, or even left atrial appendage occlusion could be considerations. But we need trials to inform our practice.
Okay, so now the next questions. So we already know that low molecular weight heparin probably will be harmful for the patients, but should antiplatelet always be used until the starting of the oral anticoagulants?
We know from IST trial that we can reduce the recurrence of stroke of every type of stroke starting antiplatelets. So in case these are based on the current guidelines, so the recommendation is follow the guidelines, start aspirin, and then switch to anticoagulation. Clearly, when you have a TAA or a very minor stroke, probably you can start directly within 24 hours. But in the other case, start with aspirin and then switch to anticoagulation.
I think we have concerns about the large infarct patients, because they might have to go on for like hemicraniectomy or other things during the first couple of days. So if you start antiplatelet earlier, that would be probably some problem with the surgeons, that they don't want to do operation on those kind of patients. So for me, I would
should not, yes.
Right. For those who are potential to have hemicraniectomy or large infarct, having high risk of hemorrhagic transformation. But the moderate ones, it's kind of controversial, I would think.
Yeah, in the UK, we definitely would give aspirin acutely in the majority of participants. But I'm not all neurosurgeons give the same answer about antiplatelets, of course, but it's a very, very good consideration. Yeah.
Sometimes they use this excuse because they don't like the operation of hemicraniectomy, so they use the excuse of aspirin. But I agree, sometimes you have to struggle.
Okay, now we have a questions regarding the balance of ischemic and bleeding. So lots of people question about the liver cirrhosis. So what about the patient already in the very bad condition of liver cirrhosis, but also having another stroke with AF? Would you still choose NOAC?
I think we'll look at the prothrombin time, the INR. If it's prolonged, we probably should not give anticoagulant because they already have anticoagulation by themselves. But if the liver function is not that bad, it depends.
I'd agree. Probably DOACs are more favorable than vitamin K antagonists in this subgroup, but they were excluded from most of the trials, or all of the trials, I think. So again, it has to be individualized, but probably DOACs are preferable in most patients. The trouble is these are such high-risk patients, whatever treatment you're going to give them, they're likely to be at very high risk of bleeding, unfortunately.
Yeah, I agree, totally agree. These are patients who need to be monitored closely, and again, very ill patients. So what you have to share this choice with patient and the relatives with caution.
And just emphasize, treat the remedial factors that can reduce bleeding risk, like really careful blood pressure.
Yeah.
Obviously avoiding concomitant medications and alcohol. And occasionally we have offered left atrial occlusion to people with extremely severe gastrointestinal tract disease, like major GI bleeds that can't be resolved. And I think just one or two perhaps with really severe liver failure. So that's another option, but a very difficult patient group.
Okay, so here is another specific group of patients. So the ones with prosthetic valves or intraatrial thrombosis, do we still use the same rules and maybe not even the same medications, not NOAC?
Unfortunately, there's no indication for patient with prosthetic valve, mechanical valve. So unfortunately, from what we know from randomized trials, there's no benefit. If you think about intraatrial thrombus, there are some evidence that DOACs, only observational studies, that DOACs are as safe and as effective as vitamin K antagonists, but again, we don't have the randomized evidence on this.
But maybe do you think the patients with prosthetic valves, they should restart the anticoagulants, even warfarin, maybe a little bit earlier, like the time frame than the normal AF patients?
Yes, absolutely.
The acceptable time window to keep someone off anticoagulation, I think, is a bit uncertain, but maybe up to 7 or even 14 days for big infarcts, you probably have a low risk of thrombosis of the valve, particularly with aortic valves, which have a higher flow, and you're going to be guided by echocardiography as well to look for high risks or cardiac thrombi, which would push you towards early anticoagulation. But this is a situation where I don't think we'll ever have randomized evidence, so it has to be a very individualized decision.
And don't bridge.
Okay, so next question is, do you will usually use SWI MI imaging for detecting maybe microbleeds before starting the DOAC, NOAC, or warfarin maybe?
So in terms of microbleeds, most of the evidence that we have suggests that regardless of the burden and the distribution of the microbleeds, so even with quite large numbers of microbleeds, more than 10, you still have a higher risk of ischemic stroke than you do of intracranial hemorrhage. So at the moment, microbleeds should not really be considered a contraindication to long-term oral anticoagulation based on current evidence. And there's also some trial evidence to support that as well from randomized trials.
I think MRI, SWI is too sensitive for the blood. For hemorrhagic transformation, you would see a lot of blood on that image, and it's going to scare you to start anticoagulant. So myself would use just only CT scan.
Yeah, that's such a good point. And the classifications of hemorrhage, you can't apply them to MRI because it's so sensitive.
Yeah.
And it looks so alarming.
Mm. I think, again, you have to see the full clinical picture. If you have microbleeds with a patient who is autonomous without the cognitive decline, okay, then you say we have to prevent a very dangerous complication. If you have a patient in front of you with cognitive decline, signs of vascular dementia, then I would also include, or in my evaluation, the microbleeds.
Yeah, absolutely. There may be a really small group with lots of lobar microbleeds and severe amyloid angiopathy who are just going to be too high risk. I absolutely agree, Valeria.
Okay, I think it's the last question here. So in case of early recurrent stroke, can we use alteplase again? Maybe the current evidence is from previous stroke should be at least 3 months. But what way for this type of the patients?
If you look at the evidence, you should not. If you look at the clinical experience, there are many patients who did it. So again, we don't have to, if you look at evidence base, I should say no. If I look what is the clinical experience, I say try it and evaluate well the risk benefit. How you probably do some more images to treat them.
And if it's a large clot, then obviously do a thrombectomy. I think within days I'd be very nervous about giving alteplase again, but depends how big the infarct is, doesn't it, I guess. Luckily, it's probably not a common scenario.
Okay. Well, I think we've all answered most of the questions here. And thanks for all our speakers again for the inspiring and very interesting talks. And thank you everyone for joining us. I'll hand over to Alina, who will wrap up today's talk.
Thank you, Ye. I can also only say thank you to Valeria, Nijasri, and David. Excellent talks and a really engaging discussion. And I can see that there are still questions coming in. What's left for me to do is announce our next webinar, which is scheduled for February 26th. So mark your calendars. It's going to be a really interesting session, stroke and the brain and heart axis. We're actually planning on a brain heart week from 21st to 26th of February, and have invited speakers Simona Sacco, Jan Scheitz and Luciano Sposato, and Sheila Martins, our president-elect, will moderate this session. As mentioned in the introduction, this webinar will be recorded and will be uploaded in the webinar archive on the WSO website. So you're welcome to rewatch it or send us comments either on Twitter or under the email education@worldstroke.org. So thank you again. I wish you all a good day and a good weekend, and see you soon. Bye.
Bye-bye. Thank you very much.
Bye.